Good afternoon, everyone. My name is Chidiogo. I'm a pediatrician and a health services researcher at Cincinnati Children's. And today's session that we are going to be focusing on is designing more equitable social care. So the presentations in this session really highlight how careful attention to the ways in which social care is implemented and who is at the decision-making table can lead to more equitable health outcomes. So our speakers for today that will be talking through their sessions and their information is first we have Stacey Thomas, who is the Director of Programs of Health Leads. We have Andrea Jimenez-Zambrano, who is an instructor in the Department of Pediatrics and an AP CRF Fellow with ACORDS at University of Colorado. And then we also have Danielle Varda, who is an associate professor at the University of Colorado, Denver, at the School of Public Health Affairs, and CEO of Visible Networks. And we also have a very special, I always like to emphasize, really our trainees, our youth, and we have Kyra Stoute, who will also be joining her in the session. Like I said, my name is Chidiogo. I will be your moderator for today. And our lived experience discussant is
Lisa Hamlett. Yeah. Hi, everybody. How you guys doing?
And so Lisa will also be joining us. Again, like I said, she's a lived experience expert. And you've seen that featured in many of the other sessions. And so we'll be engaging with Lisa in dialogue for today. Before we get started, we just want to go over a couple of the agreements for a safe and brave meeting space. We have seen this being used at a couple of the sessions, and we will do the same here today. I do not want to read all of them to you. I'm just going to highlight a few, and I'm going to ask Lisa to also do the same. I think to go in with the theme that we've been hearing today, also starting with the plenary session that we had today, really, if I get some hand claps and emojis going on, is really being mindful of positionality and power dynamics, something for us to be important to know. And then the one that I always have to be mindful of, I'm reminded of it daily, hourly, weekly, is acknowledgements of judgments and assumptions. I have my biases that I bring into any conversation in any space I enter. And so acknowledging that as we enter into the safe and brave space for meeting today. Are there any that you'd like to highlight, Lisa?
Yes, I have two that I would like to read. One would be to release control, privilege, and notions of being right. Okay, I think everybody, as long as we all have that same notion, that we can have a more productive session. And the other one would be respect each other's differences and backgrounds.
Awesome, thank you so much. The last thing that I want to highlight before I turn it over to our first presentation is that there are really ways to engage. We have been in the Zoom fatigue, conference virtual framework for the last couple of days, last couple of years, and it can get really hard to engage. But we really do believe that we can continue the levels of engagement we've seen in the other sessions here in this session. We can do that by using our chats. So the chat function, also at the very bottom of your Zoom feature, you can see the reactions tab. You can click on that and you can hand clap if there's something that someone says that really resonates, or the heart emoji or the thumb emoji. If you're really advanced, you can do the caret arrow on the reactions and change it to the hand clap, or man, that was fire, and I want to let that person know. There will come a time in our Q&A, which we hopefully will be able to get to, where we may engage people to ask questions and have you come off of mute. But before that, we just ask that you keep yourself muted, but that you turn on your camera if you can, so that we can stay engaged. So with that, I am done with my portion. I'm going to stop sharing, and we will start with our first presentation. And that is Andrea.
Well, thanks for letting me know I'm first.
I apologize. You were first.
So let me just make sure that everybody's seeing the right screen, which I think you're seeing. Is that better?
Yes, it is.
Great. Well, thank you so much. Good morning and good afternoon to some of you on behalf of our Decipher team here in Colorado. I'm so excited about talking regarding our findings today. So first of all, I just want to thank the Siren Conference for this virtual platform. And today I am presenting from the state of Colorado. And I just want to honor and acknowledge that the University of Colorado's 4 campuses are on the traditional territories and ancestral homelands of the Cheyenne, Arapaho, Ute, Apache, Comanche, Kiowa, Lakota, Pueblo, and Shoshone nations. Further, we acknowledge the 48 contemporary tribal nations historically tied to the lands that today we call Colorado. So first of all, I just want to highlight that asthma is a chronic disease for children that disproportionately impacts low-income families. Asthma is the leading cause of children's hospitalizations, emergency department visits, missed school days, and because children miss school, parents also missed work days. Poorly controlled asthma leads to educational disparities and inequalities that specifically impact children of minority and racial families. So over the past 2 decades, our team has worked on a program that has shown to be effective in reducing asthma health disparities by reducing healthcare utilization and school absences in children in urban and low-income areas here in Colorado in the Denver metro area. These schools are mainly have mainly Latinx populations. So that's what our program has been doing for the past 20 years. So in the year 2020, we received NHLBI funding to promote health equity by scaling out this very effective program across diverse regions here in the state of Colorado. So this currently funded program focuses, like I said, on expanding this evidence-based intervention to different diverse, small rural communities outlined here in this map. You can see we have the Greeley-Fort Morgan community, Colorado Springs, the Lower Arkansas Valley, Montezuma-Cortez, and also Mesa Delta. Just to go into a little bit of detail about what the program is, the program includes active care management of asthma, which not only targets the parents and helps them to understand better what asthma is, but it also talks to children about what asthma is, how to take their meds, and how to just be better at managing their own asthma. And in addition, this program includes the screening and addressing of unmet social needs. So our approach is mainly looking into moving evidence-based programs into actual practice. So in the planning phase of this NHLBI grant, we focused on understanding what success of this project will look like for each of the 5 regions that I outlined in the map. We consider success across 4 different domains, which included school, child, family, and healthcare providers. However, for this presentation, I will focus on the method that we use to build consensus and the outcomes of success specifically for the social determinants of health. And this is from the perspective of community members and in the different regions. So what we did was we created community advisory boards in each of the 5 regions. They were multidisciplinary and included a total of 39 members. 93% of the CAB members were females. 49% of the members were healthcare providers, 23% were school nurses, 20% were parents, and 8% were from social determinants of health agencies and local public health departments. So now I'm gonna explain what method we use to build consensus. We use nominal group technique as our consensus building method, and this process moves across these 6 different elicitation stages. So I'm going to walk through every one of them. The first stage was generating ideas. We conducted qualitative interviews with CAP members, and we also conducted brainstorming sessions. And we recorded these ideas. And this is our list. So this was the list that was produced from each of the different CAPs. So this is a list that includes all of the priorities that all of them came up with. So we can see we have health literacy, availability of educational resources, language justice, referral and use of food banks, housing stock and quality transportation resources, and the documentation and tracking of social determinants of health obstacles. So then the next step was the discussion of ideas. And we're gonna be moving clockwise on this figure to get to the final step. So basically that list that I showed to you guys was presented to each of the CAPs. And what they did was they talked about what priorities they found that were more appropriate for the communities they lived on. We asked them, we first did preliminary voting, just because it's really hard for people to, out of a list of 8 to come up with 2. So we did some preliminary voting. And when we were doing the voting, we asked participants to focus on what could be feasible and accomplished within the scope and the resources of our program. So then after the preliminary voting, there was another voting session, and then we came up with the final vote on 2 or 3 priorities that each region chose. So here are results. We added letters so you can see which region picked, which outcomes they picked. So as you can see here, there was diversity across regions. We can see that one region couldn't agree in 2 outcomes, so they picked 3. And we were open to that. So based on this list, the only outcome that didn't make it to the final list was housing. And you can see how addressing housing within a school-based health program is a little bit hard. So that wasn't voted as the final outcome, but you can see intersectionality between the priority outcomes. So for example, 2 of these outcomes address health literacy. So A talks about addressing health literacy needs for the parents and the families. It was important for our community members to make sure that all the material that was gonna be shared with parents was tailored to their literacy level, and it had all the information that they were gonna be able to understand and that was gonna be helpful. One specific community, and this was the Meso Delta community, took it even a step further, and they chose language justice. And for them, what this meant was in their community, they have high numbers of refugees. So they share that a lot of the refugees in that community, they don't, although they're able to speak their language, they don't read in that language. So we decided not to, use money to translate materials that community members weren't even going to be able to read. So what we decided to do to target that was to actually have community translators to be able to explain the program with those communities so that they can decide whether or not to participate. We can see that transportation resources was a big one. And as you can imagine, living in a small rural area, there is a lot of proximity between specialty care, also referral and use of food banks, and the documenting and tracking of social determinants of health for one community was important. And for us, documenting and tracking could allow us to learn how we can better serve the communities. So in summary, our nominal group technique allowed us to work with 5 regional CAPs to identify what outcomes of success will look like in each of their communities, and making sure that their voices were heard. I mean, if you remember the map that I just showed you, there was a lot of variety. So you can't just try to track the same things in different communities when their priorities are different. So it was important for us to tailor how we're going to track success for each region. One limitation that we had was that the parent and the community members only comprise about 1/3 of our CAPs. However, we just recently finished conducting interviews with parents just to get a better sense of barriers and facilitators to accessing asthma care, and just to have a better sense of their needs and what we can do as a program to tailor our program so that it works better for them. So our work fits perfectly with the equity theme of this whole conference, and our results are a great example of the intersection between implementation science and health equity. The identified priority outcomes specifically impact racial and ethnic minorities, so they're important to take into consideration. This work has implications about how we tailor evidence-based programs to different regions. In particular, for our program, it informed the implementation strategies that we're going to use, as well as what outcomes we're going to track and report back to the CAPs, because we're not only gonna listen to what they want us to track, but we're also gonna share this information back to them so they can see the progress of the program, and they can give us their feedback if something is not working and what we can do to fix it.
Thank you so much.
Oh, what was that? And finally, this process may be replicated in other studies. And finally, I just want to thank our community, our state advisory boards, and the whole Decipher team. Thank you.
Thank you so much. And now we'll move on to Stacey Thomas.
Sorry about that. I was trying to share my screen. Can everyone see my screen?
Yes, we can. Yeah.
And we're going backwards. Sorry about that.
No worries at all.
You get a preview of what it is that
in that we see some of the questions in the chat, and we will try to get to them during the session.
Okay, well, I'm sorry. I'm going to have to do something to escape out of this for a second, because I need to get to the beginning of my presentation, and now we'll do this.
Yeah, you are ready.
There we go.
Got it.
Much better. Okay. All right. And so just want to say welcome again to everyone, and thank you for joining us this afternoon, morning, wherever it is that you might be. And I'm going to be talking about informed consent and how that can be a driver of inequity. We'll take a look at some case studies that will demonstrate how they've been able to address concerns and inequities to kind of redesign their informed consent processes. And first, if this is going to cooperate. Yeah, there we go. Okay, so I'd like to tell you a little bit about the agency that I work for, Health Leads. And Health Leads is an innovation hub that addresses the deep societal roots of inequities that impact health. We operate in 23 states, providing both hyperlocal and national programs or initiatives that aim at advancing racial health equity. And we partner with communities and health systems to address systemic causes of inequity and disease. And we do this by removing barriers that keep people from identifying, accessing, and choosing the resources that everyone needs to be healthy. And so I want to kind of move on to taking a look at informed consent and how it's connected to data and how that's collected and stored. But, there's been an expansion of social care programs recently to address social determinants of health. And there's also been an increased demand for health information technology to collect, store, and share that data. And it's taken a while for informed consent to become codified, even after becoming a legal set of regulations and practices on the ground. Violations of the rights of human subjects in the context of human research continued. Excuse me. So with this expansion that we're talking about, it's important to kind of take a look at whether or not the voice of the community is or isn't involved in the decisions around how that data is collected, stored, and shared. And we're taking a look at how all of this impacts things from an equity standpoint. And our work keeps resurfacing it. And this has also been important historically. So the demand is driven by well-resourced institutions, including healthcare, market investments, government funding, and others. And as a result, there's a significant imbalance that plays out in communities of color, where the community referral networks, or referred to as CRNs, often lack community governance, exclude organizations, or burden the organizations to engage. Informed consent is a critical component, as it is a policy and a practice. So there's been, an increase in the demand for technology, but there's also been an increase in the amount of money that's being invested in social determinants of health by healthcare, both in the public and private sector. And there's also been a monopolization around social needs and a connection to historical concern about consent. And the people with the most power and money are the ones who are least concerned about the impact of this. So if we take a look at this picture graph, you'll see that the approaches to social determinants of health range from targeted population issue, pilot programs, all the way up to whole person or generalized care. And you'll notice as we move across the axis here at the bottom, the degree of involvement, the more that you have various groups of folks represented being involved in the approach, the more equitable that approach is as we move towards more whole person care. And usually most programs are focused on enhancing screening and referral capabilities. And there are significant gaps in connecting a diverse set of initiatives together or soliciting input from the community to inform design. So informed consent is a critical component of community referral networks, as you know, and informed consent is one of the founding principles of research ethics. And the intent there was that human participants can enter research freely or voluntarily with full information about what it means for them to take part, and that they can give consent before they enter the research. Informed consent was prompted through a series of legal decisions in the early 1900s through Moore versus Williams, Pratt versus Davis, Rollator versus Strain, and Schollendorf, hopefully I'm not mispronouncing that, versus the Society of New York Hospital. And those are cases in which practitioners were making decisions without informing or receiving permission from patients. So as a policy and a practice, informed consent as a policy and a practice that's intended to provide protection and choice for individuals, it falls short, particularly for communities of color, where there's a lack, and there's a lack of deep roots for communities of color. And there are well-known cases underscoring the harm that's been done to Black and Brown people. A famous case that most folks have heard about is the Tuskegee study that started in 1932, where there was, it was the longest non-therapeutic human subject study, and there was no informed consent and outright deception of Black men who were the subjects in the study. And modern data exchanges, their informed consent methods may limit or eliminate choice for those who are most impacted, deepening inequities. So the following case studies explore how community referral networks, or CRNs, manage legal and regulatory aspects of informed consent and seek to understand what meaningful consent is for patients. Using focus groups and interviews, CEOs and patients identified issues and gaps with current processes and ways to redesign informed consent. Organizations can be compliant with informed consent protocols, but still not sufficiently accountable to the deepest, ethics and principles around community owning and driving data. An example of this is how 211 San Diego has all of the data compliance and legal protocols in place, but also goes one step further, goes beyond that with having an ethics committee. And this initiative is looking at consent in 2 places in the telephonic workflow. So when the call center staff are consenting to provide housing screening questions to inbound callers who have not identified housing needs, or being homeless or in crisis, and 2, the caller can consent to to answer the housing screening questions. The workflow is unique because services will be delivered whether or not the staff or caller consent to answer the questions, and the call center staff are often people with lived experience, previously or currently. There are 3 points of consent, and so there were issues that were identified around lack of services and having a concern about whether or not there were services or resources available to meet the needs, and the wait time, because there was a report by consumers as they called in around, how long they had to wait to speak to a staff member to address their concerns. And so the solution was to obtain input from incoming callers on consenting to answer questions and then adjust when the questions are implemented during the call or in the workflow. And this case study is about an HIE in New Jersey, a health information exchange. And the site knew they needed to identify barriers to the organizations signing up. So they're trying to get people to sign up. And on their site, they were able to gain knowledge that was confirmed by listening tours about the accountability and trust, which were barriers to participation. And what they ended up doing was taking a look at what kind of consent was being used. And they identified that there was a blanket consent that was used, which meant that one consent was used for all activity. Behavioral health providers typically had more detailed segmented consents, and their concern was around who might have access to the data, which was an unintended impact. For example, law enforcement or educational institutions were places where patients' data on medication or substance abuse could be punitive. And so there's a question about why would they need access to the patient's health information. Community members were interviewed through peer discussions that used guided imagery to describe current state and design a better informed consent experience. Individual staff at the community-based organizations and at the backbone organization for the HIE described a concern as it relates to accountability. And the question was, how will they know that there is fidelity to the data protection and security, not only through technology, but across staffing and procedure? And then how does the institution demonstrate the same level of vulnerability? Ultimately, informed consent for this HIE is part of the larger question about vulnerability and accountability. And the solutions may be part of the larger work on accountability that the HIE is exploring, particularly as it, okay, I'm almost done, particularly as it relates to trust building and demonstrating not only accountability, but sharing vulnerability. And so our conclusions, and I need to move this out of the way, excuse me one second. Okay, to focus on identifying improvements to meaningful consent by engaging users to understand concerns in areas of comfort for different organizations, and then consider how institutions, organizations, and agencies can demonstrate accountability. Thank you.
Thank you so much. And last, but certainly not least, yeah, woo! All the emojis. Look like, let's find one. I said to use it and I'm not even doing it. Here we go. Hand clap emoji. And now we're going to end with Danielle and Kyra.
All right. Hello. My name is Danielle Varda. I'm the CEO and founder at Visible Network Labs and an associate professor at the University of Colorado, Denver. And with me is Kyra Stoute, who's a marketing student at Georgia State University. I'm going to introduce her in more detail in a moment. I just want to start with an acknowledgement of the people who've worked on the project that I'm going to present today. We have a team at Visible Network Labs and also a group of youth fellows that I've worked on studying social connectedness, adolescent social connectedness together. And also I'd like to acknowledge Dr. Kimberly Spring, who is the Director of Research and Evaluation at Annie Casey Foundation, who funded this work. I'm excited to have Kyra with me. She is one of our youth fellows and just a real amazing person, as you'll see. She's a marketing student at Georgia State University. She collaborated with us to work on this project as a social support fellow, and presently she is a RISE fellow, which is a nonprofit created by student advocates for free college and student loan relief, mobilizing her peers to make informed voting practices for their future. So no lack of busyness. So happy that Kyra, you have time for us today. At Visible Network Labs, our goal is to make invisible networks visible, and we're focused on trying to look at a whole system of connections and how those systems interact to affect health, mental health, and wellness outcomes. And our unique lens is a network science approach. So we create technology and tools like this, which allow people to draw pictures of things like social connectedness, describe the quality and nature of those connections. And basically, we're trying to use this kind of innovative approach to give people new voice to talk about really hard things that affect their mental health and health outcomes. All right, so the work that we did that we're reporting or presenting on today is related to this Youth Social Support Research Fellowship. So I'm just going to introduce it, and Kyra is going to lead most of this discussion. We're focusing on adolescent connectedness because I don't think this will be news to anyone. We know that youth connectedness is an important protective factor for health and well-being, but we also know it's a really difficult thing to capture and understand. And so we're working really hard, especially for youth, to figure out different ways that we can bring this to bear in ways that they're comfortable with and that make sense to them. This is just a little example. This is actually my daughter when she was 8, using one of our tools called Partner Me. And our goal with this fellowship was to better understand youth social connectedness and think about ways we could bring that learning into the tools in all kinds of different ways, including in terms of age, racial, gender identity, and different kinds of factors that are important to folks. So this fit into the Annie Casey work, and they are focused very closely on this kind of thing. So really grateful for their support. And lastly, before I'm going to pass it off to Kyra for a minute, there's a whole bunch of information about this fellowship. The fellows have produced reports, short reports, long reports, and there's a link here that we'll put in the chat. But we encourage you to go. They have been presenting with us, but it was really important to the foundation, to the Annie Casey Foundation, that we don't just have youth advisors on this project, but that we included our youth on our research team. And so they met with us every week or every other week at some point, consulted on all parts of the fellowship, start to finish, conducted the research, and as you'll see today, also present. So I'm going to turn it over to Kyra now to describe a little bit about the fellowship and how we got started and how she became a part of it.
Thank you, Danielle, and thank you, everyone. It's a pleasure to be with you all today. So I will go ahead and start. So with the background, how I came to know about the fellowship, well, I was nominated by Ashley James. She is the director of Atlanta Glow. It's an organization that serves underprivileged and low-income girls in Atlanta. And she saw that I had a passion for connecting with others and community. So she thought it was a good idea that I explored it, and I was excited to begin. And so how we got started on the fellowship, first, they really walked each of us through the concept about social connectedness and using network science to explore that.
Good.
Yeah, sorry, next slide, please.
Thanks.
Okay, and this was a really fun part. So when we were designing the research, first we started with the qualitative research, which would be the interview. So we would all collaborate together and really come together and create questions that go in depth about family dynamics, how the youth would interact with their peers versus adults in their lives. And I think that gave us a whole lot of results that were useful to the study. We really focused on being inclusive as well. So we tried to keep the questions as open-ended as possible. And we heard a lot of interesting things. A lot of the youth identified themselves with not just only by binary genders. We had a couple non-binary participants, as well as people from all sorts of racial identities. We made sure to open it up to anyone of all religions as well, or no religion. And what we learned about collecting the data, well, I want to say that going in, I had some assumptions at first. With gaining interviews with my peers, I kind of assumed that being that a lot of young people tend to use their technology a lot, be on the phone, computer, whatnot, it seems as if we're kind of distant from each other. So I kind of was a bit intimidated, like how would I go about, what would be my strategy to get people who would want to participate? Well, I was proven wrong. I've met a lot of people who were eager to share their stories, and we can move forward.
Okay. So I'm going to go through a couple of slides of the findings, but Kyra's going to actually talk through the interpretation and reflection on them. So just you can imagine, we did so much work with them over a year and a half, interviews, focus groups, and surveys. It was really important for us always to let the fellows' knowledge and expertise guide not only doing the work, but the development of the questions that we would ask people. So I'm just going to go through this somewhat quickly, because as you can see, Kyra's reflection and interpretations are much more valuable. In our qualitative work, we recruited people from different parts of the country, ages 14 to 24, and the fellows led most of these interviews. For our quantitative methods, we did have them use the Partner Me survey and that network science perspective to talk about and address these questions about social connectedness, the kind that Kyra has just laid the foundation for. You'll see some results here, for example, across gender identity, a split between mostly women, but also some non-binary genderqueer questioning folks. And you can see our kind of differences in race. So we had a really nice sample of differences in terms of helping us understand the responses. So I'm just going to go through just a couple of them. Some things that we saw, for example, in gender differences was that twice as many women as men identified future planning as a need. But in terms of our racial differences, 75% of Black youth identified future planning as a need compared to 27% of our white youth. And then on the other side, 72% of white youth identified transportation as a need, which far exceeded our other areas. We just pulled out a couple of things that we wanted to discuss. Areas where white youth reported receiving more help than youth of color. Around anxiety and depression, you'll see really strikingly here that white youth reported much higher levels of having help with depression than our youth of color. But areas where they reported similarity in getting help was around dating and relationship conflict, worried about paying bills. And really interesting to us, we saw in the surveys that 35% of youth of color indicated that none of these areas were areas that they needed help with. And that left us with a big question mark and a lot of questions. So I'm going to turn it over to Kyra, and she's going to talk through what some of this meant and what we found in their reflections from the fellows on why we might have seen some of these things.
Yes, so through talking to each of our interviewees individually and going through the surveys and the answers that were provided to us, and of course, based on my experience, I know that a lot of youth of color are socialized to not ask for help, or certain topics such as mental health are still taboo, and we really should work on that. I hear more of my white friends, peers, talk more openly about anxiety, depression, and they're willing to be more vulnerable, whereas vulnerability is, I would say it's more discouraged within youth of color. I can even say within my own background, we're more encouraged to be strong and to focus on other necessities such as, finances, school, whatnot. And I also wanted to mention that this has negative repercussions, because the more that we hold these things inside and not acknowledge them, this can lead to very serious issues such as the rising epidemic of suicide among Black men, which I found in an article by the University of Houston. And I even saw a video about 2 months ago by a nurse where she was discussing how many of the older people who are dying alone in the hospitals are actually Black men. And she attributed this to not having any family, burned bridges, poor connections. So these are habits that are socialized from our youth, and they stay with us as adults. These are the repercussions. And I also found that this was a common theme, especially in the qualitative research. A lot of the youth quoted that they were intimidated or were afraid of being judged for needing help. Whether it was because of stigma or because they couldn't trust anyone. So when I reflect back, I know that my assumptions are not always right. A lot of young people are actually very eager to talk about these things, regardless of color, regardless of income and age group. And I think it's really important to have authenticity and just present yourself in a casual manner and listen to people, because that's what majority of the youth really long for people, especially their adults, to listen to them.
Mm-hmm. Well, great. I know we're just at time, so I'm just going, I'll just wrap it up and just say, I'm going to skip right through these, but we're using all of this information and these learnings to take it back into the technology and try to make it more appropriate for the folks that we're delivering it to. So Kyra and I wanted to share our contact. If you'd like to get in touch with us, we'd be happy to carry on the conversation. Thank you.
I already know, Kyra, like when you check your email later on today, there are just gonna be like 5 or 6 emails. I mean, I wanted to just open it up first by first thanking all of the speakers. And I wanted to ask Lisa. Yes, Lisa's been clapping on there. I'll clap with this reaction emoji here. Lisa, I wanted to open it up by asking if you could, what was it about, we started out this session talking about really the main things we want to focus on is, who is at the table making the decisions and how are we going about it? And so with these 3 different presentations, one that was looking at how we get permission for getting connected to services, looking at how we work with family and community members to decide what is the priority, and then how we engage youth in the research so that they're not being researched, as we heard in the poetry and the plenary session. What stood out to you from your lived experiences? What were some of the things that resonated with you from these 3 different talks?
Okay.
One thing. I know that's a lot.
Hi, everybody. Yes,
but if you could share.
Yeah, this was a lot of content, and it was very good content. I would just like to say that to all 3 presenters and Kyra as well. Excellent job. This is something that needs to be discussed in a more vast setting, but we're getting started here, so this is excellent. I'm going to start off with the last segment with Danielle and Kyra, and I do think it's very important for young people to get a handle on their own self-worth and their own self-being. And part of that is learning how to take care of themselves. And if they have the resources available to them so that they can maneuver it themselves, yes, they need to still stick in, talk to mom and dad about things. But most of the time, most of the youth, at least the ones that I've worked with, they don't tell their parents everything. They just don't. So if they have tools available for them where they can get access to these resources, I think this needs to be done right away, because there's so much going on and they're suffering. A lot of these kids are suffering. I'm sorry if I say kids, but a lot of these young people are suffering, and because they're overwhelmed with so much. And to give them this tool, that way they can manage it on their own, I think is a very good idea to do. That's really good.
Absolutely.
And
And then one more
about
thing that's not to,
and let's see, about with Stacey, it was amazing because I didn't realize the broadness of the consent form. So thank you. Know about anybody else, but I did not know the broadness of the consent form. And I do think that definitely needs to be addressed as well as soon as possible, because people don't mind, especially if you're of a low income status, people don't mind helping out and wanting to be part of the research. It's just the trust factor. You just have to, it's the trust factor, and making sure that, are you just taking my information for your own self-gain, or are you going to take my information and actually do something about it to help us all out? What is the reason for you doing all this research? And the last one, I'm sorry, who was it? Andrea.
we're on a roll, Lisa.
I know, sorry. I didn't take my notes
One
because I
more.
can't remember.
We're almost on time, but yes, go ahead.
So
Sure.
Andrea, I think with the asthma, this is very good and it's a very good tool. I also am very ignorant because I did work in a Title I school district for 17 years and was completely unaware that they do not have, and not in every school district, that they have an asthma protocol, set in place where parents can get resources, can have access to some of the things that you had mentioned, which are the resources and stuff like that. The one thing that I do want to say about all the presentations, that we can't just cookie cutter everything, because sometimes what has happened to me is they've looked at my race and they've looked at my economic status, and they feel as though that's the way I was all the time. So my economic status changed from when I was a young person and a child to something different now. And they equate my treatment based on that.
Yes.
Not knowing that that I've actually had a life where I've been very active and I've always watched what I've eaten. But because you look at me, you don't think that I have. Just like you don't think that I used to go whitewater rafting. You don't think that I swim. All these kind of things come into play when I'm trying to get treatment from a physician. And that kind of racism really needs to, you know, it really needs to not be there, because as with me, I am suffering now because of bad medical care, because they chose to use stereotypes in trying to prescribe treatment.
Yeah,
Yeah.
and that is really, thank you, first of all, for sharing your reflections on all of the experiences, and also for being open, and the point that Kyra made at the end about being vulnerable, about, you know, that lived experience that has allowed you to be expert. We're over time. This always happens. We don't have time for the Q&A, and I just feel like really bummed. But one thing I just want to recognize that you said, Lisa, too, and that really came through from all the discussions is, whether you're calling it consensus building method in Andrea's presentation, or talking about informed consent, or about social networks, through all of your sessions, you talk about voice, about choice, and about trust that can come when we recognize the expertise that lays in the people that we partner with in doing this work, making sure that they have a seat at that table so that they're involved in the very fancy, you know, technological or scientific terms that we use for this work. So that really, with that, we will have to end, but I just wanted to thank you all so much for sharing, and also thank you so much, Lisa, for reflecting on that. Have a great rest of your session.
Thank you.
Everyone. Thank you all.
Thank you, everyone.